Welcome everyone to the SAB's February educational webinar, Drug-Induced Interstitial Lung Disease and Lung Cancer. Before we get started, just a few housekeeping items to go over for our attendees. Everyone has joined in a listen-only mode. Please ask your questions throughout the lecture by using your question feature, which is located on your control panel. We will address all the questions with Dr. Hameed after his lecture. At this time, Dr. Gupta, who is part of the SAB's Education and Program Committee, will be moderating the session and introducing our speaker. Dr. Gupta.
Thanks, Emily. Hi, everyone. I'm so excited to introduce our speaker today, Dr. Asif Abdul Hameed. Him and I have gone through training together at Henry Ford and are now colleagues. He is part of our interstitial lung disease program and has been on staff for about a year now. He has interests in epidemiological trends when it comes to connective tissue diseases related to interstitial lung disease. And with that, Asif, I will let you take over.
Thank you, Dr. Gupta. Hi, everyone. As Dr. Gupta mentioned, I'm Asif Hameed. I'm one of the senior staff physicians at Henry Ford. I'm going to turn off my webcam so I can go on just presentation mode for my slides. You're able to see my slides okay, I think. I'm going to be talking about drug-induced interstitial lung disease and lung cancer patients, and primarily focusing on the more recent molecular targeted therapy, immune checkpoint inhibitors, and the changing landscape of this. I have nothing to disclose relevant to this talk. This is my outline for the talk. We'll be discussing some introduction to drug-induced interstitial lung disease, going over epidemiology of it with focus on lung cancer treatments, and then talk about some pathogenesis and risk factors, clinical features, radiology and histopathology, and then go over diagnostic criteria, focusing on the Fleishner Society position paper that was published in CHEST a couple of years ago, and then go over treatment considerations. My primary focus is going to be based on the European Society of Medical Oncology's recommendations in terms of treatment of drug-induced ILD, specifically in lung cancer patients, and then we will focus on the molecular targeting agents and immune checkpoint inhibitors. In terms of interstitial lung disease, I think it's really important to kind of revisit this, that not all interstitial lung disease is pulmonary fibrosis. ILD is more of a broad terminology, with some patients having pulmonary fibrosis. And within interstitial lung disease, the idiopathic interstitial pneumonias and IPF form a separate subcategory. There are more than 150 ILDs. This is something which we talk to our patients about every single day in terms of how difficult it can be to understand the confusing terminology. It has been described as an alphabet soup in a sense, because overall, a lot of our interstitial lung disease share similar symptoms, radiology, and physiological findings. And in terms of the clinical, radiological, histopathological terminology, this can be very different to what the actual etiology is. And a terminology which is clinically or radiologically important may not be reflective of the actual etiology. And also, I think a better terminology or more descriptive terminology for interstitial lung disease maybe is what is called as diffuse parenchymal lung disease, because not all pulmonary fibrosis is restricted to the interstitium. There is pulmonary interstitial lung diseases can involve areas outside the interstitium, including the alveoli, the blood vessels, and overall diffuse parenchymal lung diseases are subcategorized into these 4 broad categories. The known diffuse parenchymal lung disease is secondary to a known cause, the idiopathic interstitial pneumonias, the granulomatous diseases, and the miscellaneous ones. And within the DPLD big umbrella, and within the known category of diffuse parenchymal lung diseases is where we find drug-induced interstitial lung diseases, being a part of the diffuse parenchymal lung disease secondary to unknown cause. And this is an excellent, on the right is an excellent, pie chart from the Lederer paper, which kind of described the more recent trends of how the distribution of interstitial lung diseases is. About 20% is related to IPF, 20% is chronic HP, 20% is connective tissue disease related ILD, 20% is sarcoidosis, and essentially everything else forms the rest of the 20%. So focusing on this big category of what the interstitial lung disease that are secondary to unknown cause, we have things such as connective tissue diseases, asbestosis, and silicosis, which form a broad category of pneumoconiosis that come within this, hypersensitivity pneumonitis, and drug-induced ILD is another important category that is within this subgroup. Talking about a little bit of a historical perspective, one of the earliest mentions of drug-induced lung disease was by William Osler in the 1880s in the Montreal General Hospital reports, when he first described opiate-induced pulmonary edema as a manifestation of drug-induced ILD. Moving forward to a few years, this is from the 1970s. Dr. Rosenau from the Mayo Clinic wrote this excellent article about the spectrum of drug-induced pulmonary disease, and at that point, only about 20 drugs were identified to cause interstitial lung disease. This was published in the Annals. Dr. Rosenau out in Mayo Clinic, he was teaching even into his 80s, and he passed away in the end of December 2021. And this is dedicated. The talk is definitely dedicated to Dr. Rosen and Dr. Camus, who was also who basically established the Pneumotox website and wrote this excellent book, which was also a part of it was published in the European Respiratory Review in 2011, describing drug-induced lung disease in more detail. And in this review article back in 2011, about 200 drugs were identified. So overall, drug-induced lung disease are a large and heterogeneous group of diseases that occur as a response to drug exposure. As of now, more than 450 diseases have been reported to cause ILD, and these numbers continue to rise. And the main reason for the increase in cases is the exponential development of anti-neoplastic drugs with specific mechanistic targets. And what this includes are the monoclonal antibodies, the molecular targeted agents, including the epidermal growth factor tyrosine kinase inhibitors, and the immune checkpoint inhibitors. The manifestations range from just mild disease to progressive and life-threatening disease. So very wide range of manifestations and very varied radiological and histopathological patterns. And drug-induced lung injury may not, as I mentioned earlier, may not be restricted to the interstitium and cause pulmonary fibrosis, but can also involve the pleura, the airways, the mediastinum, and also pulmonary vessels. In terms of the epidemiology, as with a lot of our interstitial lung disease, it's very difficult to estimate, and you can have a wide variety of reported epidemiology. Exact frequency is definitely unknown, but the disease is likely underdiagnosed. In one cohort of patients, in previous cohorts of patients that have studied this, studied ILD epidemiology in general, about 3 to 5% of all ILD is related to drug-induced interstitial lung disease. This 2018 systematic review looked at about 156 papers and described more than 6,000 patients with drug-induced ILD, and they mentioned an incidence of anywhere from 4 to 12 cases per million per year. And of these, not surprisingly, anti-neoplastic drugs account for 1/4 to almost half the cases. Of these anti-neoplastic targets, I think the really important ones are the epidermal growth factor receptor tyrosine kinase inhibitor, erlotinib, and also the more newer HER2, which used to be called HER2, but now more recently called ERBB2 antibody drug conjugate, which is the trastuzumab deruxtecan combination, and the other immune checkpoint inhibitors. Another important, I think, another retrospective cohort study from Japan looking at 770 patients with drug-induced ILD, specifically in non-small cell lung cancer patients, reported a 6% incidence of developing pneumonitis with a mortality rate of almost 36%. So pretty significant numbers there. Focusing specifically on EGFR and, as I mentioned, the HER2 antibody drug conjugate, trastuzumab deruxtecan. In this first study, this was a nested case control study. Basically, the controls were 3 times the number of cases. And this was a Japanese inpatient database review of all diseases associated with interstitial lung disease. They reviewed 42 categories of drugs. The EGFR inhibitors were associated with the highest risk with an odds ratio of 16. Looking at the HER2 ADC, trastuzumab deruxtecan, this was a study that looked at all of the studies that have been, I think it was 8 studies, I'm sorry, that looked at trastuzumab deruxtecan. They did a pooled analysis of all the Destiny trials and the other studies, and they saw that the risk of ILD was almost 16%, significant numbers there, with a mortality rate of about 2.5%. In terms of overall epidemiology, I think it's the year 2000-2001 was extremely important because this was when the tyrosine kinase inhibitor Geftin was introduced in Japan, and following this, the numbers have significantly increased. Another important point is that there has been a reported higher incidence of drug-induced lung disease in Japan. On the right in this box, you can see that the incidence of drug-induced ILDs when compared to Japan and outside Japan, we see that the incidence is definitely higher, suggesting that there may actually be a genetic predisposition to drug-induced ILD as well from an epidemiological standpoint. After discussing some introduction epidemiology, moving to important pathogenic factors in drug-induced ILD, there have been several mechanisms that have been described either alone or in combination. Some of these include direct damage to the alveolar cells, specifically in chemotherapy drugs. But what is even more important for us are the free radical mediated injury, and more importantly, the dysregulation of the immune system that plays a role specifically in immune checkpoint inhibitor toxicity. Another important pathogenic principle is the Hampton hypothesis, and this basically defines that the drug-induced ILD is due to an immunological effect by direct haptogenic modification of tissue-resistant proteins, in tissue-resident proteins. So basically, you have an development of an antigen-antibody complex followed by the inflammatory response. So this table basically describes all the mechanisms that have been implicated to cause interstitial lung disease in drug-induced ILD. And our focus, as I mentioned, direct toxicity is important, specifically in cytotoxic agents, but also more recently, dysregulation of the immune system, which has been described in checkpoint inhibitor toxicity and other biologics. In terms of risk factors, so which of our patients are at higher risk to develop drug-induced ILD? And this is mostly focused on lung cancer patients. So the risk factors can be divided into patient-related risk factors and cancer treatment-related risk factors. Patient-related risk factors, there are major and minor. In terms of the major risk factors, history of smoking, pre-existing ILD, previous history of drug-induced ILD, poor functional status, and advanced stage of lung cancer are probably the major risk factors that have been associated with drug-induced ILD. Other risk factors include age, male, gender, Asian ethnicity. So again, this trend of seeing more and more patients, especially in Japan, studies that have been done looking at this have shown that Asian ethnicity is associated with higher risk of drug-induced ILD. And prior treatments, and obviously comorbidity, so mainly kidney failure, diabetes are also associated with higher risk of drug-induced ILD. In terms of cancer-related factors, cumulative dose of and duration of treatment is important, and also combination agents. So more and more we have reports of patients who receive both the EGFR tyrosine kinase inhibitors like geftinib, osimertinib. In combination with immune checkpoint inhibitors, we see higher incidence of drug-induced ILD when using a combination of these therapies. Specifically for EGFR-related ILD, again, pre-existing Japanese ethnicity and smoking. And in terms of the immune checkpoint inhibitor, I think what we also saw was there is a seasonal distribution, so there may be some suggestion that viral infections may be implicated in the etiology and pathogenesis as well that has been identified. Genetics, I think, are really important as well, and this is something which, with ILD, progress of ILD towards focusing on genomics, transcriptomics, and proteomics, gene sequencing has definitely become a major, major development in the field of ILD. And similarly, in drug-induced ILD, genetic factors have been suggested to contribute. And again, focusing on the Japanese cancer patients, there was this Uragawa and colleagues, they studied 26 cancer patients in Japan and performed whole gene sequencing. And they found two polymorphisms that have been identified with increased risk of ILD. And focusing specifically on the EGFR TKI induced ILD, they identified 7 single nucleotide polymorphisms that were also associated. So along with this, there have been HLA alleles that have also been implicated, and these are the HLA alleles that have been implicated in various studies to be associated with higher risk of ILD. So after discussing the etiology, pathophysiology, moving towards the clinical features and workup. So in terms of clinical manifestations, overall in drug-induced ILD, the clinical manifestations can be very non-specific, and different patients can have different symptoms even with the same agent. Up to 1/3 of our patients can be asymptomatic. The rest can have non-specific symptoms like worsening dyspnea, cough, low-grade fevers, and weight loss. On auscultation, bibasal crackles are the most commonly elicited exam finding. In patients who have been on checkpoint inhibitors, we have a whole array of adverse effects that can involve any organ in the body. And on the right, you see this pictograph of different organ manifestations. And this is being described as the immune-related adverse effects. So our patients can have manifestations of outside the lungs, specifically with immune checkpoint inhibitor toxicity. Another important point about clinical manifestations is the time of onset can be very variable. Typically, we anticipate drug-induced ILD within weeks to a few months after starting treatment. But overall, in chemotherapy, sometimes there can be a very long latent period. In patients who, in one of the older agents, carmestin-induced pulmonary fibrosis, is actually seen even 10 years after administration of the medication. In terms of how we classify the severity, this is based on the CTCAE classification by the NIH. The CTCAE stands for Common Terminology Criteria for Adverse Events, and you have the 5 grades. Grade 1 are asymptomatic patients who only have radiographic abnormalities. Grade 2 are mild respiratory symptoms, and these do not deteriorate the patient's quality of life. With grade 3, the symptoms are more severe, and they lead to worsening of quality of life and limit patient activities. Sometimes there is need for supplemental oxygen therapy as well. And this is regardless of how severe the radiographic findings are. So as long as patients are significantly symptomatic, they would be within the grade 3 category. Grade 4 are very severe disabling symptoms, typically requiring hospitalization and need for mechanical ventilatory support. And grade 5 are the fatal complications. And the temporal association between drug exposure to onset of clinical presentation is also used for classification. So you can have an acute reaction, more of a subacute course, and the chronic. And within the acute manifestations, you have pneumonitis and diffuse alveolar hemorrhage, and they typically present within hours or days. Patients can have peripheral eosinophilia, and if they have DAH, then hemoptysis can also be seen. With more chronic, our patients typically have progressively worsening dyspnea and exertion, and can also over time develop pulmonary hypertension, right ventricular dysfunction. So we can have clinical signs of these as well. In terms of evaluation, our history and physical exam is important, mainly to rule out other causes of having interstitial lung disease. We are going to go through some of the laboratory testing that is commonly performed, imaging, PFDs, need for bronchoscopy, molecular markers that are being studied and that have been studied. And finally, I think the most important piece of all of this is once we have all of our information, we have our multidisciplinary discussion to discuss consensus recommendations. In terms of lab findings, for drug-induced ILD can be very non-specific and typically are used to exclude alternative etiologies. Eosinophilia can be seen in patients with drug-induced ILD who present as eosinophilic pneumonia or even hypersensitivity pneumonitis, but some patients who do not really have a full-blown eosinophilic pneumonia pattern can still have mild peripheral eosinophilia accompanying drug-induced ILD. On PFD's restriction is the most commonly reported abnormality with decreased diffusion capacity, and decreased diffusion can sometimes predate restriction on spirometry. So you can have decreased DLCO as one of the most initial changes, sometimes even before radiological changes appear as well, and sometimes obstruction can also be seen. In terms of imaging, chest X-rays can be normal, especially in the initial phase of the disease. HRCT is the imaging modality of choice. It has high sensitivity, not just in recognizing and diagnosing the disease, but also defining the extent and also suggesting other alternative diagnosis. But HRCT findings may not be very specific because the same drug can actually be associated with multiple patterns, and in the same patient, you can have multiple patterns of disease as well. So the position paper from the Fleishner Society, which was published in Chest in 2021, is I think a very important review. They not just provide a description of radiological patterns, they also propose diagnostic criteria and provide management recommendations. So an excellent read. And their recommendations were to have a radiological pattern approach. They recognized 5 important patterns of drug-induced ILD, and describing these patterns, not just radiologically, but also histopathologically, and then basing treatment and etiology from these patterns, I think is a very good approach. So in terms of the radiological patterns, they subdivided this into the acute interstitial pneumonia, so AIP, which is also called diffuse alveolar damage pattern. Very difficult to differentiate AIP from ARDS. In certain patients, you can have the transient simple pulmonary eosinophilia pattern, and this is also acute in the temporal association between drug exposure and the findings. In terms of the subacute disease, we see organizing pneumonia and the HP pattern, and more chronically, we see the NSIP pattern. We'll be going through the radiological patterns in more detail in subsequent slides. So following getting a good history and physical, doing some labs, and then also getting PFTs and CT scans, we now focus on the role of bronchoalveolar lavage in drug-induced ILD. So in certain conditions, BAL can be diagnostic. So it can be diagnostic to rule out infections. BAL eosinophilia above 30% would be diagnostic for eosinophilic pneumonia. And also if you were to find malignancy on cytology, I think this would be diagnostic as well. It has some role in diseases outside of these. BL can have some role outside of these diseases that are absolutely diagnostic, and that it can give us certain indicators for sarcoidosis, for HP as a manifestation of drug-induced ILD. Most commonly in drug-induced ILD, we see a lymphocytic alveolitis pattern, and there may be a preponderance of CD8 cells. So BAL helps. This pictographic on the right, the picture on the right is basically a BAL cytology showing intracytoplasmic phospholipid accumulation. And this has been more commonly described in amiodarone toxicity, but that is another one that we can think of, which can help sometimes BAL cytology. Do all patients need lung biopsy? The answer is no. Lung biopsy has a role. It has a limited role in some cases. The reason it may not be very important because any histological pattern, so even if we get a lung biopsy and we find a pattern, this is not particularly specific for drug-induced ILD. So any histological pattern can be seen. It is more useful when we are uncertain about the diagnosis. And as I mentioned earlier, it does not really confirm diagnosis in most cases. So the more important reason to potentially obtain a biopsy is to rule out malignancies, and especially important when the diagnosis is uncertain. In terms of the type of biopsies we have, transbronchial biopsies, we have transbronchial lung cryobiopsy and surgical lung biopsy. And this flow chart here is from the 2022 IPF guidelines that were published in the Blue Journal. And for the first time in 2022, if you were to look at the way in which the diagnostic algorithm for working up interstitial lung disease, once we have a pattern that is consistent with which is indeterminate for UIP, and on subsequent slides we'll go through what these patterns basically means. But if you have a UIP pattern or a probable UIP pattern, then following a multidisciplinary discussion, we can give them a diagnosis of IPF confidently. But when we have an indeterminate pattern or a pattern that's consistent with an alternative diagnosis, then BAL with transbronchial lung cryobiopsies, especially in centers that are experienced with cryobiopsies, can be used as an alternative to surgical lung biopsy. This was for the first time in the 2022 guidelines discussed the role of cryobiopsy in diagnosing interstitial lung disease. So transbronchial cryobiopsies, I think, are more important when we have a centrilobular diffuse disease pattern. So things such as hypersensitive pneumonitis, workup of infections and neoplastic processes are also important, and they can be used. That can be a utility of using transbronchial biopsies. There are certain diagnostic limitations. Obviously, a smaller size, the possibility of crush artifact are important, and the inability to reach subpleural areas is a limiting factor in transbronchial lung biopsies. Cryobiopsies, as you're aware, I'm speaking to advanced bronchoscopy, so you guys are probably well aware of the limitations and the advantages of lung cryobiopsy. But sometimes, I know there are a few centers that also do this in moderate sedation, but generally, general anesthesia is required. The sample size is definitely bigger than what we get with transbronchial biopsy, so cryobiopsy is definitely superior to just TBBX. In the 2022 guidelines, the recommendations were actually based off of this systematic review that was performed that looked at 40 studies looking at the diagnostic yield of cryobiopsies, and this was found to be about 79%. So the guidelines, as I mentioned earlier, recommended that they suggested actually that the cryobiopsies can be used as an acceptable alternative to surgical lung biopsy to make a histopathological diagnosis, and but the caveats being that the centers should be experienced not just in performing but also interpreting cryobiopsies. How about surgical lung biopsies? We know that surgical lung biopsies are the gold standard, but there was a systematic review meta-analysis that was included in the 2022 guidelines, which included 26 studies. Although we had the possibility of getting a diagnosis was pretty high, 88%, the mortality rate was almost 3.5%, and the risk of post-op complications limits our utility of using surgical lung biopsies in our patients, with persistent air leak being almost 6%. In terms of biomarkers, the KL6, Krebs1, and lungin 6 protein, glycoprotein, has been studied in ILD overall. In a prospective study, about 53% of patients with drug-induced ILD had increased levels, and also KL6 elevations were correlated with a more severe diffuse alveolar damage pattern and more extensive involvement. But this is not ready for real time yet. Another test which is used in Japan, and it's not FDA approved yet, is called the drug lymphocyte stimulation test. They sensitize lymphocytes from the patient, are collected and are mixed with the offending drug to see if there is essentially an allergy, and they subsequently used thymidine uptake by the lymphocytes as a marker of the immune response. But this drug lymphocyte stimulation test has poor sensitivity, specificity, and as I mentioned earlier, is used mainly in Japan. So again, not ready for real time yet. So as I mentioned, once we have a history and physical exam and we look at the radiological patterns and the other workup, we move towards a multidisciplinary meeting to come up with consensus diagnosis and recommendations. Focusing real quick on some important radiological patterns and histopathological patterns. As I mentioned earlier, we have the Fleishner Society position paper described these 5 patterns. So the more chronic NSIP pattern, the subacute organizing pneumonia and hypersensitivity pneumonitis pattern, and the more acute diffuse alveolar damage and the simple pulmonary eosinophilia pattern. And sometimes you can have more than one pattern, and if that's the case, a dominant one is typically reported. There are other rare patterns that have been described as well, including granulomatous pneumonitis, alveolar proteinosis. And again, as I mentioned earlier, the CT patterns are non-specific for any particular drug, and one drug can present with multiple patterns in the same patient, actually. The UIP pattern, which we talked about initially, so which is characterized typically by subpleural reticulation, which is basilar predominant, traction bronchiectasis, and honeycombing, is a rare pattern in drug-induced ILD. And when we find a typical UIP pattern, that should raise our suspicion for an alternative diagnosis other than drug-induced ILD or the presence of pre-existing pulmonary fibrosis. NSIP pattern is probably the most common pattern that is seen overall, and drug-induced NSIP pattern is indistinguishable from idiopathic NSIP. So typically we're seeing the ground glass opacities, maybe some consolidation, usually a bilateral peripheral reticular pattern, can have predominantly lower lobe involvement. And this is all, and specific to our talk, this is seen with EGFR receptor inhibitors, geftinib and erlotinib. Organizing pneumonia patterns present with multifocal areas of ground glass and airspace consolidations. You can have certain specific signs, the reverse halo sign, and also something called the arcade sign, which is here on the right. And drugs that can present with organized pneumonia are all of the ones that are relevant to us, including immune checkpoint inhibitors and the EGFR tyrosine kinase inhibitors. HP pattern, again, drug-induced HP pattern is indistinguishable from HP that is induced by organic dust. Centrilobular nodules, poorly defined, and here on the right we have something called the tree density sign, which used to be called the cheese appearance, right? So the different patterns there, but the tree density sign is the more important one that we talk about now. And that can also be seen in drug-induced hypersensitivity pneumonitis, and HP pattern can be seen with immune checkpoint inhibitors and the EGFR tyrosine kinase inhibitors. Diffuse alveolar damage, this is more of the acute pattern with bilateral ground glass opacities, sometimes having crazy paving, and again seen with immune checkpoint inhibitors and EGFR tyrosine kinase inhibitors. Another important pattern, which is probably less common, that has been described, is something called the simple pulmonary eosinophilia pattern. And this is multifocal ground glass or consolidative opacities. It can be unilateral or bilateral. These are typically transient and migratory. And this is commonly seen with the third generation EGFR TKI, which is osimertinib. ILAs, so any pulmonary conference now usually has a talk on interstitial lung abnormalities. Since we are recognizing this, especially with our lung cancer screening programs, we're recognizing ILAs, and it's important to break them down into the different subcategories as to what we see. Typically, you have changes, abnormalities on a high-resolution CT chest, and these are incidentally identified and affect at least 5% of the lung zone. These can look like ground glass opacities. They can have some traction bronchiectasis or honeycombing as well. And these are usually early manifestations of disease. Almost 70% of ILAs can actually progress to full-blown ILD, so it's important to follow these patients closely. In drug-induced lung disease, if you were to find patients who are asymptomatic and have interstitial lung disease changes, these would be categorized as grade 1, so just asymptomatic patients. And it's unclear as to what interstitial lung abnormalities mean in drug-induced ILD patients. If how many of these are going to progress has not been specifically studied in the context of drug-induced ILD. In terms of the histopathological patterns, all of these here have been described in drug-induced interstitial lung disease. A lot of times, though, pathologists are going to describe histopathology in drug-induced ILD as something that does not fit into a unique pattern. So it's common to see an overlap of patterns. And drug-induced ILD, the diagnosis typically does not require histopathological confirmation. The more important role would be to rule out malignant infiltration in our lung cancer patients, because these can mimic ILD. Different histopathological patterns are reflective of the radiological patterns as well. So if we have the NSIP pattern, the organized pneumonia pattern, and similarly, if you have the diffuse alveolar damage and the eosinophilic pneumonia pattern. One important one that we also see is something called the sarcoid-like reaction, also called granulomatous pneumonitis, wherein we have granulomas and chronic interstitial inflammation, interstitial fibrosis, which may appear like sarcoid, which has been described in drug-induced ILD. How about concordance of drug-induced ILD, histopathology, and radiology? Cleverly and colleagues, they looked at 20 patients who had biopsy-proven drug-induced ILD and compared the high-resolution CT and histopathology. And they found that HRCT and histopathological patterns were only concordant in about 45%, although this was a small study. So in many cases, HRCT pattern can be indeterminate, and histopathology, if available, may add on to our understanding of what the exact pattern is in our patients with drug-induced ILD. So there is definitely a role for bronchoscopy and transbronchial biopsies, especially early in the game. In terms of diagnostic criteria, overall for drug-induced ILD, Dr. Kames back in 2004 proposed these diagnostic criteria. So exposure to the agent, development of pulmonary abnormality, infiltrates, exclusion of other causes, which is really important. And then the last two were removal of the causative drug, causing improvement in symptoms and imaging, and potentially re-challenge of the drug, causing worsening of the disease. But these had certain limitations, because some patients do not have improvement when you take away the drug, and re-challenge may not be possible in a lot of our patients, especially with how severe their disease can be. So more recently, Fleischner Society in their position paper, they gave the 3 diagnostic criteria. So their diagnostic criteria basically were new onset lung parenchymal opacities in a bilateral non-segmental distribution on a CT, temporal association between exposure to the agent and development of clinical and radiological abnormalities, and exclusion. And the last criteria, the exclusion, is definitely important and can be very challenging. Common differentials include pneumonias, diffuse alveolar hemorrhage, pulmonary edema, lymphangitic carcinomatosis. So typically, when we have our patients who come in and there's suspicion for drug-induced ILD, these are the things that we rule out. So we usually get an echo with the right heart protocol. In the bubble study, we do get BNP levels, and there's a whole battery of infectious workup, including respiratory viral panels and the Fungitel that is also performed to rule out fungal and viral infections that we go through. So ruling out and excluding other causes is really important. So this was a good checklist that was described in this paper by Spagnuolo and colleagues in the European Respiratory Journal, and they reviewed a whole checklist of things that we need to do in patients who are suspected to have drug-induced ILD. One of the things they mentioned was to consider the possibility of drug-induced ILD in every patient that comes in with ILD, and also reviewing pneumotox.com to see if a particular drug has been described to cause ILD, especially in a particular pattern. History of exposure to the drug, specifically the timeline is very important for our patients. So we make sure we have, our patients with lung cancer can be on multiple chemotherapy agents, and things may change over time. So really describing exactly which agents were used for what duration of time, and when the CT changes occurred is really important. So understanding the temporal association is very important. And then what was the pattern? And I think one of the important points that they mentioned in this checklist is to see if the pattern, the clinical and the imaging pattern, has been described in literature before by reviewing pneumotox.com. Other things in the checklist include exclusion of other causes that we talked about, and then drug discontinuation. So in clinical improvement after discontinuing the drug is a very important diagnostic marker. And in certain patients, if there is a re-challenge, understanding that the re-challenge can be dangerous and can make things worse down the line. This was the adverse drug reaction probability scale. So looking at a number of questions, we can potentially score, certain, based on scoring for these questions, we can provide a probability of how likely is it that the patient has drug-induced ILD, with a score of more than 9 being definite to, a score of 1 to 4 being possible. In terms of treatment, overall, discontinuation of the drug is the mainstay of treatment, and improvement after stopping the drug, with or without, especially without steroid therapy, really supports their diagnosis. So as I mentioned, in patients who are asymptomatic and just have isolated radiological changes, just closely monitoring while continuing drugs may also be an option. Steroids are used in patients typically when they have severe and progressive lung disease, but the duration, the dose, and the response to steroids can be very highly variable. There was a systematic review that looked at 156 papers and more than 6,000 patients with drug-induced ILD were evaluated, and the response to systemic steroids was reviewed, and their conclusion basically was steroids are commonly used, and they may be useful mostly in severe cases, and there have been no randomized controlled trials that have looked at this in specifically. Role of antifibrotics, I think, is something, especially in patients who have more chronic disease and more progressive disease. So if we were to look at the INBUILD trial, which was published in New England Journal in 2019, evaluating the role of nintedanib in progressive pulmonary, in what is called progressive pulmonary fibrosis now, but used to be called progressively fibrosing ILD before. So basically, our patients with chronic ILD who do have progression over time, usually 2 out of 3 criteria. So worsening symptoms, worsening PFT findings, or worsening imaging findings. So 2 out of 3 in the last 1 year would be candidates for OFEV, irrespective of the etiology. And drug-induced ILD, when it has a progressive course, these patients would be candidates for antifibrotics. And then supportive care. So these are the mainstays of treatment options that we have for our patients. And as I mentioned, sometimes using a reduced dose or re-challenge may need to be considered, but a multidisciplinary discussion and also a risk-benefit discussion with the patient is very important before considering that. And this is really important because when we re-challenge patients, almost a third of them can develop recurrence of the drug-induced ILD. So this flow chart basically looks at everything we discussed. So this drug discontinuation would be the first step, and then we need to see if the patient is a candidate for steroids. And on subsequent slides, we'll be going through different grades of drug-induced ILD and where steroids would be indicated. So if steroids are indicated, then the next step would be to reassess to see if the disease has stabilized, and if it has stabilized, then we would taper the steroids over time. But then if there is no response, then we would need to either consider other immunosuppressants such as azathioprine, mycophenolate, or if they have no response to other immunosuppressants, then antifibrotics would be a consideration. Moving on to the next few slides are going to focus on this in a little more specific fashion, and that is what would be the treatment considerations in general based on the grades of drug-induced ILD. So grade 1, as I mentioned before, asymptomatic patients just with radiographic findings. So these patients are the ones who typically, as I mentioned before, have no symptoms. And in these patients, temporary discontinuation of the offending agent is the first step. And in certain patients, we can consider steroid therapy, typically at a lower dose when compared to higher degrees of ILD. So we're usually talking about 0.5 milligram per kg per day. And over time, if there is radiological resolution, then we can taper off the steroids and even potentially consider reinitiation of the drug. Whereas in grade 2, and a grade 2 drug-induced ILD is when we have mild respiratory symptoms that do not significantly affect the patient's quality of life. And this is when we go through our workup that we talked about before. And in these patients, we would immediately discontinue the drug, and steroid therapy at a relatively higher dose, so 1 to 2 milligram per kg per day is considered. And in these patients, typically we also put them on Bactrim for PJP prophylaxis. And we typically follow these patients in about 4 to 6 weeks with repeat imaging, potentially with repeat pulmonary function testing. And if the patients have resolution, then we would taper the steroids off. Grade 3 drug-induced ILD would be the patients with significant impact on their quality of life, with worsening quality of life, potentially needing supplemental oxygen therapy. So these are the patients that are more tachypneic. They have crackles on respiratory exam. They may be even hypoxic, requiring supplemental oxygen therapy. And these patients, again, immediate discontinuation of the drug is important. We may need to consider hospitalization of these patients and steroids. And some of these patients may require IV steroids as well for a short duration, followed by a taper with PJP prophylaxis. And when we see them back, and if they have resolution, then we would taper steroids, and the taper would be potentially a longer taper, so taper them in the next 8 to 12 weeks. And if patients are still refractory, then we would also need to consider other immunosuppressive therapies as well. Grade 4 are the ones who have severe disabling symptoms and may require mechanical ventilatory support. And in these patients, hospitalization, supportive therapies, need for non-invasive or invasive mechanical ventilation needs to be considered, and steroid therapy at 2 milligram per kg per day or equivalent would be administered with Bactrim for PJP prophylaxis or other medications for PJP prophylaxis. In terms of prevention, is there a way to prevent these? If we were to look at the studies that the Destiny trials that were done for trastuzumab deruxtecan, our ERB/B2 antibody drug conjugates, we see that as the Destiny trials were done, we saw the more and more there was identification of ILD, there was a decrease in incidence and severity of drug-induced ILD when compared to previous Destiny trials. So raising physician awareness has been shown, potentially, taking, extrapolating information from this, we can say that raising physician awareness may help in decreasing and preventing a drug-induced ILD. The European Society of Medical Oncology does recommend a few things that need to be done in all our patients to prevent drug-induced ILD, and that is we would evaluate them for all the risk factors that we talked about before, getting a baseline evaluation of the respiratory function, especially in drugs that are known to be associated with drug-induced ILD. And then having multidisciplinary meetings in patients who have abnormalities and are suspicious, fast tracking their evaluation with pulmonary experts, I think, is something which is very important and is recommended by ESMO, and communication with patients, so the patients are more aware that they need to report the clinical signs and symptoms that can indicate drug-induced ILD if and when they occur. In terms of prognosis, can be very highly variable. There are certain things that there are certain findings that have favorable prognosis. So patients who have an early diagnosis and in whom the culprit drug is discontinued typically have a favorable prognosis. Patients who are diagnosed later in the course of illness or who have a more rapidly progressive course and develop ARDS have a poorer prognosis. So and I think another important point to recognize is our patients with lung cancer who are on these therapies, discontinuation of the therapies can actually be life-threatening and can make the lung cancer get worse as well. So that needs to be considered because the benefits of continuing drugs may also are really important. And And also the uncertainty that comes along with discontinuing and what the impact of discontinuation of these drugs will be is difficult to say. And sometimes we don't really have a lot of alternatives either. So all of these things need to be weighed. The risks and benefits of discontinuation need to definitely be weighed. So overall, there are a lot of things that go into understanding the prognosis. So how acute was the disease, pre-existing lung disease, having a history of smoking, older age patients can have worse prognosis. So all of these things would be considered as important prognostic factors. In the last few slides, I would like to go through some specific considerations. So overall, in lung cancer, these are some of the more important drug categories that we look at. So patients do get chemotherapy and also molecular targeting agents that target different gene mutations. And EGFR tyrosine kinase inhibitors are one of the most important ones, along with the ALK receptor inhibitors. Immune checkpoint inhibitors can be classified into 3 different categories. The CTLA4, which is a cytotoxic T lymphocyte associated protein 4 inhibitor ipilimumab, the programmed cell death 1 inhibitors, including nivolumab, pembrolizumab, and the programmed cell death ligand inhibitors, including atezolizumab and durvalumab, are more and more frequently being used. And then more recently, the ERBB2 antibody drug conjugate, trastuzumab deruxtecan, has been more frequently used, and we're seeing more and more drug-induced ILD from this agent. And last but not the least, VEGF inhibitors such as bevacizumab are also used. So these are overall the drug classes that are used in lung cancer. Focusing on immune checkpoint inhibitor toxicity, so the incidence can be 3 to 6%, with about 1 to 2% having grade 3 and 4 disease. PD-1 inhibitors are the incidence of having drug-induced ILD is probably more than PD-L1, and this is more than anti-CTLA4 drug therapy. And as I mentioned earlier, the incidence is higher when these therapies are combined. Additional other risk factors, so patients who are smokers, history of pre-existing ILD is associated with higher risk of having lung toxicity from immune checkpoint inhibitors. And typically what the societies basically recommend is patients who have ILD and concomitant lung cancer, these decisions about discontinuing their therapy and what kind of grade they fall into and what treatment considerations need to be should be discussed in a multidisciplinary setting. The different patterns that we see with immune checkpoint inhibitors, as described earlier, we have the organized pneumonia pattern, the HP pattern, the NSIP pattern. And in certain patients, you can have myositis involving the diaphragm. And as I discussed earlier, another really important pattern that is seen with immune checkpoint inhibitors is the sarcoid-like granulomatous inflammation pattern. So in patients who are on immune checkpoint inhibitors, when they develop new respiratory symptoms, the next step would be to obtain a high-risk CT. And in patients who have new lesions on a high-risk CT, we would go about ruling out other etiologies, eliminating differential diagnosis, and this would typically involve ruling out infections, potentially undergoing a bronchoscopy, assessment for cardiac comorbidities, and if the suspicion is high, then we would treat according to the severity grade, and the severity grade that we use is again similar, grades 1 to 5. So bronchoscopy and BAL are definitely useful, specifically to rule out infections. And overall, in patients who already have ILD, immune checkpoint inhibitors typically should be avoided, but again, we understand that there can be limitations to what patients can and cannot receive. But patients specifically with IPF who have extensive disease, who already have moderate to severe lung impairment, the risk of having acute exacerbations from IPF and the high risk of mortality associated with IPF exacerbations needs to strongly be considered before starting these patients on immune checkpoint inhibitors. So the ICI inhibitor lung toxicity has been the American Society of Clinical Oncology has described various management strategies similar to what we have discussed earlier. This is a good pictographic representation of these recommendations. So typically with grades 1, you may be able to continue ICI keeping a very close eye and monitoring their CT scans very closely. Steroids may or may not be used, but in higher grade toxicities, grade 2 and 3 and 4, the ICI should definitely be stopped. Steroids are administered at varying doses depending on how severe the drug toxicity is. In grades 3 and 4, re-challenge of the immune checkpoint inhibitors is definitely not recommended. And in all grades, frequent CT monitoring is recommended. This is a good case of pembrolizumab-induced pneumonitis. So A and C, and then B. And so A was where we saw almost an organized pneumonia pattern that actually improved with drug discontinuation and steroids. In C and in B and D again, in B we see almost like a ground glass. This was, again, depending on what the temporal association was, this was described as an NSIP pattern, being more chronically found that improved as seen in the figure D. Focusing on the epidermal growth factor receptor tyrosine kinase inhibitors. So you have the 3 generations. Generation 1 included drugs like erlotinib and geftinib, and more recently the 3rd generation includes the osimertinib. And the incidence of lung toxicity here is about 1% or so, with about 0.6% having high-grade pneumonitis. And again, Japanese patients were found to have more EGFR TKI toxicity, as was described earlier. The factors that are associated with poor prognosis are presence of a diffuse alveolar damage pattern, and you can find multiple different patterns as we had described earlier. So we have the organized pneumonia pattern, the NSIP pattern, the diffuse alveolar damage pattern, and the simple eosinophilic pneumonia pattern. Another important pattern that is seen specifically with the 3rd generation EGFR TKI osimertinib is something called the transient asymptomatic pulmonary opacity. So this would typically be because the patients are asymptomatic, we're talking of grade 1 disease. And what was really interesting to see is 20% of patients with non-small cell lung cancer on osimertinib, the 3rd generation EGFR TKI, had this pattern, the transient asymptomatic pulmonary opacities pattern. It was described as a simple pulmonary eosinophilia pattern. So basically either unilateral or bilateral ground glass or consolidated opacities that can be migratory and transient. These actually resolved even without treatment, despite continuing osimertinib within 6 weeks. So a lot of these patients can have complete resolution, and it's a frequently found pattern. So this is something to consider specifically for osimertinib, that you can have a pattern that basically resolves even with continuation of the drug. The last class of medication that I wanted to touch upon is the more newer ERBP2 antibody drug conjugate therapy, which is being more and more used in different cancers, including breast and more recently in non-small cell lung cancer. The Destiny Lung trial, which was published in last year, looked at this combination of trastuzumab deruxtecan. Overall, lung toxicity from trastuzumab deruxtecan is about 2.4%, with about 0.2% leading to death. Again, risk factors included age, poor performance status, Japanese ethnicity, history of smoking, pre-existing lung disease, similar to what we had seen before. The clinical manifestations and the diagnosis is similar. And the treatment options are all, the treatment considerations are also very similar. So typically discontinue the therapy, start steroids according to the grade of toxicity, with grade 1s getting typically a little bit of a lower dose and higher dose of corticosteroid therapy with higher grades of toxicity. So what do we have for drug-induced ILD in the future? Well, we have certain things that we're doing to improve diagnosis and potentially even improve treatment options. So recognizing is really important. So we're so in terms of biomarkers, especially imaging biomarkers, we're looking at a CT scan scoring system. This is called the IMAGE ILD study that is being recruited and this is basically also looking at the role of radiomics in picking up interstitial lung disease early on. Other biomarkers, they're looking at exhaled breath analysis to see if there are certain indicators in exhaled breath that could predict the risk of having more worse disease in patients with symptomatic pneumonitis. Other things that are being looked at, there's this OnTracks trial that is looking at mobile devices to detect pneumonitis in stage 3 non-small cell lung cancer patients. So basically, multi-parametric mobile devices that look at patient-reported outcomes, vital signs, respiratory function. In terms of management, and I think these are really important questions. So we have the pros-cons study that is looking at prolonged versus short corticosteroid therapy in patients with PD, with ICI, with immune checkpoint inhibitor-induced pneumonitis. We're also evaluating prophylactic inhaled steroids to reduce pneumonitis, specifically prevent drug-induced pneumonitis in patients with lung cancer. And in patients with corticosteroid refractory ILD, there's another study that's comparing infliximab and IVIG therapy as well. So more to come in the future in both the diagnosis and management. So in summary, drug-induced ILD, as we discussed, is a wide and heterogeneous group of diseases with an increasing list of culprit drugs. And as we discussed, cancer therapies are central in the increased incidence of drug-induced ILD, with specifically the molecular targeting agents and immune checkpoint inhibitors more and more frequently being associated with drug-induced ILD. The clinical, radiological, histopathological features can be non-specific, even with the same offending drug. Bronch and biopsies can definitely help in refining our diagnosis, are very important in ruling out infections and malignancies, but I would consider them early in the course of the disease. Treatment, drug withdrawal, supportive care, steroids, specifically in grade 2 disease or above. And I think it's important to remember that just because a patient has drug-induced ILD does not necessarily mean that the offending drug needs to be permanently discontinued. In certain patients, we can re-challenge after discussing in a multidisciplinary meeting and having a risk-benefit discussion with our patients. And this is especially important because a lot of our patients may not have alternative therapy that is available. And with that, Pneumotox, an excellent website to look to see if which drugs cause what kind of patterns of drug-induced ILD. But overall, we reviewed the therapeutic implications of all of this. This is our ILD team at Henry Ford. We are 3 physicians, and we are a PFF care center network site. We have our partnerships with other specialties, including radiology, pathology, our excellent interventional pulmonary team and advanced bronchoscopy team that help out with a lot of our diagnosis. And this is a wonderful picture of Detroit. And with that, I'm done. I'm happy to take any questions.
Thank you so much, Asif, for that very comprehensive talk.
Thank you, Rudy.
A few questions for our attendees that are on the call. If you have questions, please feel free to type them in the chat box. Some questions that have come in, Asif. In this post-COVID kind of post-pandemic era, how do you interpret these radiographic findings in patients that have had COVID or were recently diagnosed with COVID and are also getting treatment for lung cancer?
So I think excellent question. So with COVID, what we're seeing typically is over time with having radiological surveillance is really important. A lot of our patients are with COVID specific disease, we find that they're having improvement of their lung parenchymal interstitial findings over time. In some patients, definitely post-COVID fibrosis is a separate entity. It can worsen over time. And in these patients, if they have not just radiological worsening, but also in addition to it, either symptomatic worsening or having worsening on their pulmonary function testing, if they do qualify for the diagnosis of progressive pulmonary fibrosis, then antifibrotics would definitely be a consideration in these patients. Lung cancer patients overall, I think, COVID can definitely be one of the differential diagnoses. Any infection for that matter can be, in the differential diagnosis of drug-induced ILD. But in the acute phase, it will be very difficult to differentiate drug-induced pneumonitis from COVID that is overlapping, but then over time, those COVID changes tend to improve, is what we have seen. And again, it's really early on. But if there is worsening, we do know that COVID in certain lung diseases does cause worsening of pre-existing ILD, and in those patients, if down the line, if they have progressive pulmonary fibrosis, they would be candidates for antifibrotics. I hope that answers your question essentially.
Yeah, thank you. Now, in this, you went through workup and diagnosis of ILD. At what point would you want to see a patient with suspected cancer treatment-related ILD in your clinic? How much of this workup can be done by a pulmonologist out in the community? How much can the oncologist, try to coordinate for the patients? I guess more for physicians that are out in the community, when do we send them to a subspecialist or a specialty center?
I think there are two aspects of to that question. The first one is too little and too much, right? So too little is what I think is more prevalent in the community, is what I have seen. So a lot of times these patients get started on steroid therapy even before they come to us, and sometimes as I mentioned earlier, the duration of steroids can be, and the dose of steroids can be very variable. In certain patients, we have seen really high dose of steroids. In certain patients, we've seen typically very low dose of steroids, which may be ineffective in a sense. And a lot of times, we like to do follow-up imaging, and if there is a resolution, then taper off the steroids. But sometimes these patients just get left on or administered, a 3 to 4 week trial, and then there's really no follow-up. So that's number one, and that is, I think, making sure that the patients get the appropriate dose and they get a reasonable duration of steroid, and B, there is follow-up, and only if there is radiological resolution, tapering off those steroids after. I do know that there are some oncological societies that actually recommend just a 4-week course and there's no tapering down, which I think is probably not suited for most of our patients. I do think a lot of our patients, we need to see the radiological resolution and then potentially taper those. So I think there is definitely more and more education that comes along with this. So so in the community, I do think that if there are well set guidelines about how to approach this, then I think it is okay for these patients to be managed in the community. But then if there is any question about what is the grade of ILD here, and how do we approach this, and what dose do these patients need to be put on, and sometimes we see these patients who get 4 weeks, 5 weeks of steroids, and they have no PJP. Sometimes they don't get PJP prophylaxis as well. So keep in mind that these patients do need, have lung cancer, they already are immunocompromised, and they're going on steroids. So having the PJP prophylaxis. So if everything else is done and physicians are comfortable in the community managing this, then absolutely. But then if there is any question about what the duration of therapy should be. And the other thing I think is also important to consider is early, more aggressive diagnostics. So sometimes, what may happen is there are changes on the CT with an agent that is being increasingly recognized to have drug-induced pneumonitis, and those changes get diagnosed or get labeled. Sometimes even with positive PET scans, they get labeled as just having pneumonitis, but there may be a recurrence of malignancy there. So the patients actually lose a considerable amount of time from a cancer diagnosis standpoint as well. And I do think being considerate and being cognizant of those things is important. And if these can be done by community pulmonologists, oncologists, then absolutely. But if there is any question about what is the differential diagnosis, what is the duration of steroid that is required, then absolutely we're happy to help out, and we would like to see them early so we can make some of these decisions. The other important thing is to consider is multidisciplinary meetings are extremely important, especially with having a chest radiologist on board, and physicians, ILD physicians who do this more frequently maybe better suited to handle this. So even if the patient is not being sent to us for a full-blown evaluation, but if we have, if ILD multidisciplinary teams are able to contribute to how things need to be done, I think that would also help community pulmonologists and community oncologists deal with this.
Yeah, absolutely. Do you know if there's any literature that's out there commenting on patients' life expectancy when it comes to just interstitial lung disease related to these cancer therapies?
Yeah, so and again, I think it's very, very variable, and it also depends on everything we talked about earlier in terms of prognostic factors. So in certain patients, you can have a very favorable prognosis, specifically the ones who we have identified the culprit drug very early on, the drug gets discontinued early on, very favorable prognosis, as opposed to some patients potentially have a more acute course and they develop ARDS, then yes, the prognosis is more poor. And also in terms of, if they have a more chronic disease, then yes, the prognosis is poor. So I think it can be very variable. The other thing to understand is the grade of pneumonitis. So in certain patients, we're seeing, and depending on what their drug is. So a mortality rate of 1% is still considerable, especially with how many patients are being treated with drug-induced ILD. So overall, the grade 5 pneumonitis, which is considered fatal, depending on the class of drug, can range from 0.5 to 1%. But again, I think there are many, many factors that go into that.
Sure. And then for the sarcoid-like granulomatosis reaction, how is treatment for that different than sarcoidosis that we see in normal patients? Is that any different?
Yeah, I think so. Sarcoidosis that we see in normal patients, I think, those are definitely treated with methotrexate and infliximab and other agents that are more focused towards sarcoidosis treatment, primarily. But sarcoidosis as a radiological or histopathological pattern in drug-induced ILD would be treated like drug-induced ILD, and that would involve understanding what the grade of ILD is and titrating your steroid dose based on that grade. And then potentially, if patients are needing to be or are refractory to corticosteroid therapy, or you're not able to taper them off corticosteroid therapy, then moving towards other immunosuppression would be warranted, things such as azathioprine, cyclophosphamide, especially if they have a steroid responsive course. And then, I think more recently, as I discussed, in the future, specifically with drug-induced ILD, we are evaluating the role of infliximab versus IVIG for treating patients, especially with corticosteroid refractory disease. So definitely the approach can be significantly different. I would look at this as a complete separate entity. Although the terminology is similar, the sarcoid-like granulomatous inflammation here is due to drug-induced ILD, and it would need to be treated as drug-induced ILD, based on the algorithms that we talked about earlier, and not treated as a sarcoidosis patients would be.
Sorry, I'm just reading questions that are coming in. So in patients that are immunocompromised, in terms of interpreting the CT scan for, alveolar hemorrhage versus pneumonia versus pulmonary edema, how do you determine kind of the length of treatment for steroids, kind of tapering them? When would you offer them further immunosuppression medication?
So typically, I think there are two questions there. The first question would be, the radiological patterns would definitely be very different. So pulmonary edema by itself should give us smooth interlobular septal thickening, as opposed to pulmonary fibrosis, which would probably give us more irregular interlobular septal thickening, as opposed to drug-induced alveolar hemorrhage, which would potentially give us bilateral ground glass opacities, airspace filling defects, airspace consolidations, which would definitely appear, although there can be overlap and they can appear similar, but there are certain findings that can guide us towards one way or the other. And some of these patients can be very challenging. There can be a lot of overlap as well. And for DAH, that is when if a patient can undergo bronchoscopy, then doing serial allocords may be also helpful as well. So I think that's kind of the first thing there. There may be certain subtle findings that can help differentiate radiologically one over the other, and in certain patients we just need more diagnostic workup. And I think the second part of the question was, at what point are we thinking of steroids? I think typically we put them on a tapering course of steroid for about 6 to 8 weeks, see them back in pulmonary clinic on a lower dose of steroid. And when we see them back in clinic on that lower dose of steroid, we're doing a more objective assessment with pulmonary function testing with repeat radiology to see what the improvement was. And if the patient has responded to steroid, they have symptomatic improvement, they have radiological improvement, or they have pulmonary function testing that has improved, then we know that these patients have steroid responsive course. In those patients, we would try to taper the steroids down in the subsequent weeks, but in some patients, we may, those patients get worse. And I just saw a patient in clinic today who, doesn't have drug-induced ILD, has a connective tissue disease ILD course, but very specific. I was doing great when I was 40 milligrams of prednisone. As soon as I came down to 30 milligrams, I felt so much more worse. As she mentioned, her radiology findings initially showed improvement, and then once we started tapering steroids, she felt worse and she had worsening. So these are the patients who we are not able to taper off the steroids, and those are the ones we are introducing steroid sparing therapy with a lot of making sure that they have age-appropriate cancer screening done, making sure that they have immunizations completed. We have evaluated them for latent infections, including hepatitis and quantiferon. And taking all of these things into consideration, then we would offer steroid-sparing therapy eventually.
Thank you so much, Asif, for this great talk. I appreciate you taking the time out of your evening to tell us more about this topic. Any last comments or words from your end, things that we should keep in mind?
No, I think the questions were excellent. So just overall, this is a very rapidly changing field. We have so many more therapies that we have to offer for our patients with lung cancer, but at the same time, these therapies can have potential complications, and being cognizant of them, early recognition, and then sending them over to an ILD team for a multidisciplinary meeting, and figuring out what the best course would be extremely important. And lastly, definitely want to thank you and the Society of Advanced Bronchoscopy and Emily for having me here and for helping us put together this talk.
Absolutely. Thank you so much.
Thank you.